computer. Now I'm going to go and make sure that I have the correct patient. So I'm going to knock, knock, tap, tap, and I'm going to introduce myself. Hi, I'm Missy Linda. I'm an instructor from ABC, and the student and I are here to insert an NG tube today. Then you're going to explain what is an NG tube. An NG tube is used, in his case, for feeding. So we're going to put it in through your nose, down into your stomach, and then we're going to hook it up to our feeding pump here, and it's going to give you water and food. Okay, water and food. So then once he's aware of what's going on, you're going to say, is now an okay time for us to proceed? And that's kind of your way of saying, is it okay if I do this rather than the nurse? If you flat out say, I'm a student, can I do it? Then he's probably going to say, I don't know. But if you say, is now an okay time, and he says, I don't want you to do this, then you can say, okay, would you rather the nurse do it? You don't really want to bring that up ahead of time because that's going to make him nervous, okay? All right, so then you're going to gather your supplies once you've gotten permission from him. And if you don't have your instructor present, you're going to go get your instructor. You're going to bring your supplies back to the room. And did I already say name and date of birth?
No.
Okay, so I should have asked him his name and date of birth and confirmed with his bracelet. That's how you're going to verify that it is the same patient that the order is placed for in the computer.
Quick question. You might have already said this, but you were just saying that it's best to wait to tell him we're a student nurse because it might make him uncomfortable.
But
so
you can identify yourself as a student. What I'm saying is if you phrase it, I'm a student, is it okay if I do this?
Okay.
Then he's probably going to get nervous. If you explain that you're a student and you're here to insert his NG tube and ask if it's okay for you to proceed or if now is a good time to do it, and he states that he's uncomfortable, then you can go ahead and say, okay, would you rather somebody else do it?
Okay.
I've found that if I go with students and they say, I'm a student, can I do this procedure on you? They get nervous and then they ask for the nurse to do it right away. So, okay. The way you phrase things counts is what I'm saying.
Mm-hmm.
So we come back, we know it's our correct patient, we've gathered all of our supplies, we set up here. Then you're going to, when we came back, we tap, tap again.
Okay.
You're going to put on your clean gloves, don't need sterile gloves. You're going to ask him to plug one nostril. If he's not able to do it, you're going to ask if it's okay for you to do it for him. He's going to breathe in and out. A little congested on that side. So now you ask for the other side. Can you tell which side is best for the NG tube? It's going to be this side for me. So you're going to find the path that's going to be the clearest. This could be caused by congestion, septal deviation. They could have prior nose fractures. All of those kinds of things can cause problems on one side rather than the other.
Will there ever be a case that both sides you can't do both sides for whatever reason?
Typically, if both sides are so bad that there's no ability to pass through, the patient's typically gone in to see somebody about it. But if that isn't the case, if they can't get it through either nostril, you can do an orogastric tube, an OG tube. It's just typically not recommended for awake patients because it's very bothersome for them. We tend to do OG tubes or orogastric tubes on patients who are intubated. It is a possibility, but it's much harder to stabilize that tube and keep it in place. Okay, so what we're going to do next is we're going to measure. So now that we've found which nair we're using, we're going to measure from the tip of the nose to the itself policy, the lobe of the ear down here. I tend to go a little around the ear just to make sure I don't end up in the esophagus. I like to give myself that extra little bit of wiggle room. So I go around. And then you go down to the xiphoid process. You all know how to find the xiphoid process?
Yeah.
Okay, good. So you find the xiphoid process, and that's where you're going to mark. You are allowed to go like this, but like I said, it's just my preference to go around to make sure I don't end up in the esophagus, which is more dangerous than going too far. Mm-hmm. Okay? All right, so once I have my marking, I'm going to take my tape. Okay, well, not sterile, so we're okay. I'm going to mark the spot that I was at. Now I'm going to let me think for a minute. I want to remeasure from here to here. And that kind of gives me an idea of how far the tube needs to go in before we switch from the first position to the second position. You want the patient up at a 45-degree angle. You can go higher than that, but for this first part, this should be fine. You want the patient to put their head backwards like this, extending. What that does is it straightens out the nasal canal, the passageway. If it's like this, it's not going to be straight, it's going to be curved, and you'll have more chance of damaging the tissues. So if they're able, have them place their head, extend their neck, and at this point you want to lubricate that, at least that first part with the holes in it. I'm not actually lubricating because the mannequins get damaged with this lubricant, okay? If you feel that you really need a lubricant, we have a spray. It's an oil-based spray, and you can use that, okay? So we'll say that it's lubricated. We're going to use the nair that we identified, and he is probably going to be uncomfortable during this part, okay? So it's more uncomfortable.
That's when you put the swab thing in his mouth?
No, the swab's going to be next.
Next, okay.
Yeah. For this part, okay, and with the mannequins, you're going to possibly have to force it. You do not want to do that with a real patient. You want to wiggle around and see if you can get it to pass through without forcing it, because that could damage tissues. You're going to find that with the mannequins, you kind of have to do that. And that's okay as long as you remember to state that I'm not going to force it on a real patient, okay? Okay, once you reach that point that you had, which is about there. And another way that you can tell if you lose track is you can use your pen light and see if you can visualize it at the back of the throat. You might take your tongue depressor and you use your pen light. If your instructor's there with you and you feel like you need an extra hand, they can hold the pen for you. And then you'll see it there. That's also the thing that you're going to do if the patient starts coughing or gagging, is you're going to check to see if it starts coiling when you start advancing, okay? All right, so the next step is you might want to raise them up a bit.
So, question, what was the first measurement you took where you decided to stop right there?
Let me take it back out here. We measured from the nair to the ear.
Okay.
And that tells you about how long it's going to be until it gets to the throat.
The full round of the ear, reaching the lobe?
This is fine.
Sorry.
From the nose, tip of the nose, to your lobe. That's what the policy states. So you can use that, that's fine.
Okay.
You said you like to go around?
Yeah,
That's
when
to
I'm doing
measure
the
in the-
initial measurement, yeah.
Okay.
To make sure that it's not too short and ends up in the esophagus. So once you've lubricated it and you have your point, use your other hand to help guide it into the nostril. And again, this guy doesn't have the best. Okay, that sounds easier.
Now, when you're putting this in a real patient, if you're feeling like it's getting stuck, you said just
I said
twist
you're
a
going to
little,
maybe pull back a little bit, twist,
and then
and keep trying to maneuver safely without damaging tissue. So once you reach that point, they no longer have to hold their head back. They can now bring their head forward. The reason behind bringing the head forward, if they're able to, is it closes off the epiglottis and prevents it from going into the lung. If the patient has neck injury, you can't do either movement, right? You just have to go with it. But if it's possible, you want them to initially put the head back so that it goes in more smoothly, then put the head forward so that it does not go into the lung. I like to sit them up for the second part a little bit higher if they are comfortable with that, because it does help them to do this naturally rather than you having to hold their head the whole time. That can get heavy. All right, so the next thing you want to do is you want to continue advancing. This is the point at which you provide them with either the water and straw or the swab, depending on if they're NPO, cannot swallow, or they can swallow just fine. So we'll say he's swallowing just fine and he's going to hold his cup of water. We'll pretend he's able to hold the glass. And you're going to instruct him when you begin advancing, he's going to just take drinks of water and continue to swallow. Okay, so he's ready to go. He's keeping his head forward, and go ahead and swallow the water, okay? If at any time you feel uncomfortable or you feel like you need me to stop drinking the water, and I will stop for a moment. Okay, so his head is forward. We continue to advance. He's drinking the water. No issues, no choking, no gagging, so no need to stop. We continue to advance until our tape mark. Now we're going to take our securement device here, our tape. I'm just going to place it here on the tube. Twisting the first piece around and securing to one side. Twisting the other one once around and securing to the other side. Okay, nice and neat there. Then you're going to, at this point you need to be careful, this should probably have been in here, because you may see drainage immediately. Okay, so that could be spilling into this. And the reason for this bucket, you'll use it for the patient if they feel like they need to vomit as well. All right, so at that point, it's secured in place. I can go ahead and kink this and attach it to whatever I'm going to be attaching it to, which we'll talk about in a minute. We'll either attach it to the feeding pump or the suctioning. So we'll say it's attached to something and that it's no longer draining. If you're in an emergency and you don't have anything available or you forgot to bring something with you to attach, you can place this in here temporarily. They do not recommend that you place this in here for over like a half hour to an hour at most. So during transfers, if you have to, you can do this. But if this stays in place too long, it's going to get clogged and you may potentially ruin your tube. You can try troubleshooting with the techniques we talked about if that happens and just replace this anti-reflux valve. Okay, so now that that's done, we're going to get our measuring tape. And I believe both hospitals use centimeters, but you can check in the charting when you get there. If the charting shows that it wants it in inches, measure inches. Last I checked, it was centimeters though. So you'll take the centimeter side, which is the smaller side of your paper tape, measure from the nair to the end of the tube. And the end of this tube is actually longer than this tape. Straighten it out. 61. Plus 6.5, so 67.5 centimeters is what I would document for that. The reason we are measuring this is because let's say another staff member comes in and sees them pulling this out, they might just retape it without telling you. That could happen, and then you would just not know that it has been moved at all. So when you come in to, you check this tube every 4 hours if they're getting a feeding. You come in and you recheck it during those 4-hour checks, and if it's a big difference, then you get a chest x-ray.
Sorry, can I ask you, until what part do you measure? The blue thing also, only the white one?
Just till here. If it's attached to other tubes, don't pay attention to those tubes, you stop here at the end. Okay? Alright. So now that you've measured, you can secure it in place to their gown. And the way that you do that, you want to leave slack here so it's not tugging at their nose every time they turn their head, okay? So you're going to leave some slack. You'll attach this, just like that. And then you're going to pin it to their gown. Just remember that if you change their gown, you need to unpin it first. So if you see an NG tube, pay attention to that. So that's pinned and ready to go. His NG tube is inserted. You can verify placement. The golden standard for verifying placement is a chest x-ray. So once it's inserted, we typically send them straight to chest x-ray. For a quick check, you are allowed to pull back 30 cc's of air. Always kink your tube if you're going to expose the tip here. Attach the cap tip syringe. Use your stethoscope, place it on the left upper quadrant, which is where the stomach is at. Insert the air. You should hear a whoosh. When you practice on the dummies, it's not going to sound the same. So when you get to the hospital and you have your first NG2 patient, try that and you'll hear it. Once you hear that, you can be fairly certain it's in the stomach, but you really can't be 100% certain unless you have a chest x-ray. So they will typically do, I believe it's daily chest x-rays for NG tubes. That's how it is in the ICU. Can't be sure on the floor. But if at any time you do your auscultation check, you could check the pH. We don't really do that anymore, but it is one option. You can check the color and consistency of the stomach contents that you withdraw, and you can check, I believe that's all of them. So those are your 3 options other than your chest x-ray. Oh, and your measurement. If any of those things points to that it has been misplaced, you can order a chest x-ray. I believe it's a standing order. You don't even have to call the doctor. You have to check with the institution that you're at. Okay, so once that's done, you send them to x-ray. You may not insert anything into the tube until after you have verified that it is correctly placed. Once the chest x-ray shows that it is in fact in the stomach, not in the esophagus, not in the lung, not in the way too far down in the small intestine, if you pass the duodenum, they won't digest properly. Once all of that has been verified, now you can check stomach contents, push them back in if you need to. You can attach to a tube feeding. You can administer medications. I believe that they want you to send for chest x-ray before you connect to suction too, but I'm not 100% sure that it's required because you're not putting anything into, you're just taking things out. But if you were in the lung and you do connect to suction, they will automatically have trouble breathing. Obviously, it's suctioning the air out of their lung. Okay, let's quickly cover the tube feeding. I'm just going to leave my gloves on here. This is where you would put flush water. It's blue, so it's the same color as water. You open here, put whatever amount of water you want to, close it, and reattach here. This can be the same drinking water that you give to patients. Okay, it doesn't have to be sterile water. We might use sterile water for administering medications via a tube, but we don't have to put it in the flush. Okay, it's just drinking water. The kangaroo purple bag is where you would put the tube feed. Now at the hospital they have specific, they already pre-filled jars, and you just spike those with a disconnected tube that looks like this. You just spike that. So we'll show you that when we actually get to the hospital. What you do is you're gonna turn your kangaroo pump on with the power button. It will tell you load a set, and that's what this is. Keep setting. See this flashing button? And it says load a set. That means that you need to insert the actual tube. So if you've programmed everything in perfectly and this is hanging here like this, and you click start, it's not going to let you do anything. That actually has happened to people before. So just read your whole screen and you'll find that it says load a set, and then you'll remember that you just need to put the tubing into the machine. So it shows you a diagram of what you need to do. The bigger piece with the piece sticking out is going to go in first, and you're going to have the piece sticking out obviously facing away. You'll wrap it around this circle, pull, you're going to have to put some traction on it, and place there. That's how you load the set. Okay, then you just close it here. You're going to need to prime the tubes. You don't want a bunch of air going in. Seems silly because we do push air in to test for auscultation, but they want you to clear this first. And what it says is prime pump, the top button. And you can click auto prime, and that will automatically prime it to not the end of the set, but about a couple inches away from the end. Once it stops there, then you would just click the hold to prime feed or flush, whichever one you're doing. So you'll prime your, I like to prime my flush first. You prime it all the way through, and then I prime my feed, and then I can see, the feed is much easier to see. I can see it all the way through. When it gets to the end, I stop. So you prime it either into the sink or something you have handy close by, like that cup, and then you just dump it. Once you've primed it, you're going to click done. Adjust feed is the second button. You click that button, you put in the feed rate, whatever rate was ordered, and you click enter, the top button. The second button here says feed volume to be infused, so you would put whatever amount is in your bag or pre-filled container and click enter. Then you click run, and that will start running the feed. But you can't do that until you've attached it to the patient. So you would use, can you hand me that little orange piece right there? The orange, yeah, there you go. Thank you. This is called a Lopez valve. It comes by itself. It includes this long piece, this thing with the turn, and this cap. The exposed piece here, it might come not assembled. So the long piece is what goes into the tube. Remember to kink your feeding tube first. Insert the long piece here. You want to turn it off to the patient so things don't spill out while you're working with it. The off button will be facing the tube. You place the orange on the shorter end here. You place the primed tube here. This is where you would administer medications or withdraw residuals when you're checking residuals. It's also where you'll insert the air. I recommend that you insert the air and auscultate, then withdraw the residuals. As much residuals as you can pull off. Each time you will have the off facing the orange button, attach the tube, turn it off to the feeding. Now it's open to here and open to the patient. You can push the air in and listen. Start pulling residuals. I recommend that you hold here so that it doesn't pop off and start spilling stomach contents everywhere. I got a full 60 and I needed to keep going, so I push off to this port, and you might find that it's difficult to hold on to this tube. You can place it at the center right there. Okay, it's off. I'm going to push this into my container. I like how you backed away like there's real stomach contents. Okay, and then you continue to pull. Attach it, put it off to the feeding, hold on to it, and withdraw. Let's say at 20, excuse me, at 20 mLs, if I feel resistance and I can't pull anything off, I'm done. I turn it off here. There's 20 plus 60. How many residuals do I have? 80. That's what I'll document later. And I put it back. Unless it is over 400 mLs, they don't recommend that you get rid of it or hold it to the side. They recommend that you put it back.
So is the residual what's left after digestion?
It's because it's either stomach fluids for digestion, but most of it's probably going to be feeding that has not yet been digested. So
So how often do you do that?
every 4 hours. I believe on the floor it's still every 4 hours until you reach your goal rate without complications. If you've reached your goal rate and you don't have a ton of residuals and things like that, they do move it to every 6 to 8 hours, I believe. Okay, so, but of course, if this patient starts vomiting or things like that, then you need to reassess anytime something happens that makes you wonder if it's not being tolerated.
And your goal rate is pretty much like how much
what was
has been ordered.
You don't start it at what was ordered. You start it slowly and increase it. You might start at 10 or 15 and increase it to every 10 mLs every time you go in for a check, something like that. Or you might check it more frequently in the beginning and see if they're tolerating and increase it every time you go in. Yeah, because if you started immediately at like 55, which might be ordered, then and they haven't had any food for 5 days, it's not going to be digested. You want to slowly wake up the stomach. Yeah. Okay, so once you've checked residuals and you're done, if you have any NG tube, you guys aren't doing NG tube meds. Later on, you'll learn that you can also push the medications through there. Okay.
Wait, quick question. You said if you get residuals of less than 400 cc's, then you would put it back. So you would take the amount that you pulled out of the cup and you put it back.
If you
And
take
that's
all
not
that,
gross.
I see what you're saying. We have to check the residuals
Okay.
to see how they're tolerating it. If you leave all the stomach contents out of the patient, you're taking away a lot of digestive juices, which includes a lot of electrolytes, and you can cause fluid and electrolyte imbalance.
Okay.
So you have to
So you're just measuring then?
You're measuring to make sure that they're tolerating it. If it's
Okay.
like 500 cc's in there, you call the doctor and ask him if he wants you to put all of that back or just some of it, and he'll tell you what to do.
Okay.
Yeah.
So you're pretty much measuring to see if, okay, do we need to increase it, do we need to keep it where it's at, are they tolerating it?
Right. And if it's under 400 but you're concerned, you can always let the physician know.
Okay.
Yeah.
So when you're checking it, you're looking obviously for the amount, but like the color and what did
Yes.
you say else about it?
All that coca stuff,
Yeah,
color,
okay,
consistency.
odor.
You don't really check odor.
Okay.
Like
It's probably gonna smell anyway.
Yeah, it's not gonna indicate like infection or things like that. It's probably gonna smell like food. So color, consistency.
You said
Like
pH.
if there's a bunch of what do you call it, coffee grounds in it,
Okay.
then you would know that there's bleeding. If it's discolored red, there might be bleeding, or it might be because of a medication.
Right.
So you just want to make note of the color and the amount and the consistency. What was your question?
You said something about pH, do you guys have pH strips?
There are pH strips and pH testing, but we don't really use it because it's very inaccurate. And you can only use it if you hold feeding the medications for, I believe, an hour before you test. We don't really do that. There's a lot of other ways that we can test for it. And there's not going to be a lot of instances where there's just an NG tube sitting there for over an hour. And we don't want to be pausing it every time we want to do a check. But it is available if you wanted to. You could test it. It's not very accurate anyways. The pH, if it's in the small intestine, is the same as the pH if it's in the lung. So you see how that can be. Show you off, yeah. Okay, so I believe we got through everything feeding wise. The last thing I just wanted to show you, we have the materials for suction. This would be what you would use instead of the Lopez valve. It's called a 5-in-1 connector. This is in place of the Lopez valve, and you would connect this end to the patient and this end to the suction tubing, which I have here for you guys to look at. You would connect this tube to this end, and then the other end of the tube is going to go into, it says on here, pay attention to what it's stating, vacuum and patient. The one that says patient, you'll hook up the tube there. The one that says vacuum, I brought 2 of these because it's this length, but it's this color. The ones at the hospital, it's smaller too, but it's this blue color. You'll hook that tube up here where it says vacuum. And the other tube will hook up to, there's a small machine that will be plugged in where it says vacuum here. And it has a knob on it that you put, you could put it to low, intermittent, medium, or high suction. And you will usually place it to low intermediate suction. And you'll just hook that up to that machine. There's a piece on the bottom that you plug that other part of the tube into. So that's if you have to hook them up to suction. Last thing we need to go over is how to remove the NG tube. If they're hooked up to suction or tube feeding, regardless of what it is, turn it off first. You, of course, at this point have verified that the doctor does want the tube removed on this patient. You come in, you verify their name and date of birth. You let them know that the doctor has said that they can have their tube removed and resume eating or whatever it might be that they order. So then once they're aware of the procedure and now is a good time for you to start, you turn whatever was on off. That's off. You're going to, I actually, if there's a bunch of feeding in here or whatever's in the tube, I clear it first. I pull up 30s and there's 40 cc's, usually 30 because when you push for your air, you should be able to hear with 30. 40 is on the safe side. So I'm going to put it off to this tube first.
So you push it back in, the residual back in?
Yes, the important thing is the tube doesn't have a bunch of fluids in it. When you remove it, it could leak, and if you are removing and it leaks into the epiglottis, then they will aspirate. So I clear the tube. Off. Okay, I can see that it's cleared. And if you want to be on the safe side, you can have your stethoscope on, and if you can hear that whoosh of air, then you know for sure that it's cleared all the way to the end. And now I'm going to turn this off to the patient, and I'm just going to remove my tube feeding. So isn't in the way. This is here in case the patient vomits, which could happen during removal. You have the towels in place. I remove this part here. I'm going to instruct the patient that as I remove the tube, they should have their breath held. So before we begin, they're going to take a large breath in and hold it. Doing that will prevent things from leaking into the lungs. In the instance that there are some fluids left, it will prevent that from going into the lungs. So then at that point, we will loosen this, and then we've already told them what to do. We say, okay, I'm about to remove the tube. Go ahead and take a deep breath. They take their breath in and hold it, and you pull. This is much easier. You shouldn't have resistance like I'm getting here. It should just simply come out. You pull it. If you do meet resistance, you stop. You tell them they can breathe for a minute, and then you rotate a little bit. You have them take their breath, and you try again. Okay? Because you don't want them to be holding their breath for too long if it's getting stuck. Okay, at that point, there could potentially be fluids in there even though you cleared it. So you just wrap it up in your towel, bring it over to the trash, throw this away, put this in the linens, okay?
So what happens if the patient, like when it meets resistance and they take their breath, they inhale the food into their lungs?
Oh, you're not removing it while... They should...
Because you said to stop, right?
If you have to stop.
And then breathe.
If you have to stop.
What happens if you meet resistance where it's near the lungs?
If it's near the lungs and you meet resistance?
Yeah.
They'll probably cough, but if you're meeting a ton of resistance, it's usually in the beginning because it's stuck up against the lumen. You don't typically meet resistance as you're pulling it out. I just mean in the beginning, you don't want to force it if it's stuck up against the stomach. So typically it will come out fairly easily, especially at that point. It doesn't typically get caught there. I've never run into that, so if anything happens and they do start coughing and choking, you sit them up and you encourage them to keep coughing, and then you offer them a small sip of water once they've cleared everything, if they're allowed water, because sometimes when they're coughing, it's just because it's stuck at the back of the throat, and if they drink something, it'll push it into the right spot. If they can't swallow, then you don't do that. Okay, so that's everything: insertion, feeding pumps, suction, and removal. Do you guys have questions?
After or prior to suctioning, do you need to administer oxygen?
During suctioning?
Before suctioning.
The suctioning will be from the stomach.
Oh, okay.
Right, so it's going down, in every time it should be going into the stomach. If they have problems breathing, you immediately turn the suction off. You most likely have it in the lung.
When you're removing, you're not asking the patient to look up to.
No, the
it's
looking
just
up part is only for
only
that
for
first
the insertion.
part of insertion,
Okay.
so that it can pass the nasal cavity.
Okay.
For removal, they can be
Just-
they don't have to.
Okay.
They just take a deep breath and hold it, and they can
Okay.
be sitting on that.